Hello, my name is Carlos Vega, student from medical English class of Dr. John Moscoso, and I'm going to talk about of antithrombotic therapy after an acute coronary syndrome or PCI in atrial fibrillation. So, definition. Antithrombotic treatment is a useful type of treatment to reduce the complication that can occur after an acute coronary syndrome. This therapy can help prevent stroke, systemic embolism in patients with atrial fibrillation, recurrent ischemic episode, and stent thrombosis. In general, an antithrombotic, according to the Texas Heart Institute, are drugs with the ability to prevent the formation of clot or help them not to increase in size.
I've been involved in antithrombotic therapy for more than half a century, and I've watched the evolution of anticoagulant therapy from the old standard of heparin and warfarin. And I think that the first major breakthrough was the introduction of low-molecular weight heparin in the 1980s. This truly changed the way that we manage patients with thrombosis, both acute treatment and also prevention of thrombosis. Subsequently, we developed drugs that target single coagulation factors, and the prototype of that was fondaparinux. I had the pleasure of being involved in the early work with both of these agents, both low-molecular heparin and fondaparinux, and they still remain one of the principal ways of treating patients acutely by parenteral administration of anticoagulants. Towards the end of the last century, there was a very important development in antithrombotic therapy. It was based on a much better understanding of coagulation. It was possible to target single coagulation factors. The two main targets are factor 10 and thrombin, both key in the coagulation cascade, and it was possible to synthesize drugs that target both factor 10 and thrombin to inhibit coagulation. Factor 10 is a key coagulation factor, and it's not a surprise that much of the development was targeting activated factor 10. And there are now 4 factor 10 drugs available worldwide: rivaroxaban, apixaban, edoxaban, and betrixaban. The thrombin inhibitor, dabigatran, is also available. This is an effective agent, but the development of thrombin inhibitors was set back by a drug called zimalagatran, an effective anticoagulant thrombin inhibitor, but was associated with hepatic toxicity. And there's a concern that this might be a class effect of thrombin inhibition. As it turns out, that's not the case, and the dabigatran is effective and does not have that problem. But I had the pleasure of being involved with the early development of these drugs clinically, and did some of the first dose-finding studies and subsequently the phase 3 trials, particularly with rivaroxaban, demonstrating its effectiveness both in prevention of thrombosis, treatment of thrombosis, and a reduction of stroke and atrial fibrillation. These drugs, in my view, will completely revolutionize the management of patients who require long-term anticoagulation. They are orally active, they do not require anticoagulant monitoring, and have been shown to be effective, and in many cases reduce the risk of major bleeding complications, and in particular reduce the risk of intracranial hemorrhage. So in my view, in this decade, the DOAC drugs is what we're calling them now, direct oral anticoagulants, will be the drug of choice for patients who require long-term anticoagulation.
Application in medicine. In medicine, we see that antithrombotic drugs can be used to prevent stroke or unblockage of arteries and veins or heart disease caused by thrombin in general. So in the case of anticoagulants and antiplatelets, in the case study, it has been shown that the use of oral anticoagulants in patients who have undergone PCI or percutaneous coronary intervention with atrial fibrillation showed a lower incidence of bleeding with the new anticoagulant regimen. In the case of antiplatelets, their medical application as antithrombotic for disease such as acute coronary syndrome or stable coronary disease, which are thromboembolic events due to ischemic heart disease, are the first line of treatment to prevent bleeding or further heart damage.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual antiplatelet therapy with a P2Y12 inhibitor plus aspirin are used to prevent thromboembolic events, including stroke, systemic emboli, and stent thromboses. But they are associated with a high risk of major bleeding. A potential therapeutic strategy to reduce thromboembolic events and bleeding risk is dual therapy, with the oral direct thrombin inhibitor dabigatran and a P2Y12 inhibitor without aspirin. In the multicenter randomized redual PCI trial, 2,725 patients with non-valvular atrial fibrillation who had undergone PCI with stent implantation within the previous 120 hours were randomized to receive either triple therapy with warfarin, a P2Y12 inhibitor, either clopidogrel or ticagrelor, and aspirin for 1 to 3 months, or dual therapy with dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor. The primary endpoint was time to first major or clinically relevant non-major bleeding within 14 months. The rate of major or clinically relevant non-major bleeding was 15.4% in patients receiving 110 milligram dabigatran dual therapy, as compared with 26.9% in patients receiving warfarin triple therapy. Similarly, the rate of major or clinically relevant non-major bleeding was significantly lower in patients receiving 150 milligram dabigatran dual therapy than in those receiving warfarin triple therapy. In the secondary endpoints, there was no significant difference in the rate of thromboembolic events or death between patients receiving 110 or 150 milligram dabigatran dual therapy and those receiving warfarin triple therapy. The authors conclude that in patients with atrial fibrillation after PCI, dual therapy dabigatran and a P2Y12 inhibitor significantly reduced the risk of bleeding as compared with warfarin triple therapy, with no increase in thrombotic complications. Full trial results are available at nejm.org.
Pros and cons. Pros. Used to prevent stroke and blockage of arteries and vein or heart disease caused by thrombin in general. A lower incidence of bleeding, and also drugs with the ability to prevent the formation of clots. Cons. Some antithrombotic drugs are still being investigated as there is still a risk in their use. The risk-benefit depends on the severity of the patient and should always be used with caution, and there may be problems.
Well, it's been an interesting time in the last 2 years in patients who have atrial fibrillation who need to go under PCI in getting new data to help address what should be the antithrombotic mix. And following the WOOS trial, we have done studies where we dare to stop aspirin, and that looks like it's a smart answer. The concept is that using triple therapy with aspirin, a P2Y12 inhibitor, and an anticoagulant is needed for the atrial fibrillation and the stent, and yet it leads to a lot of bleeding. And so the idea is, could you take away the aspirin and have less bleeding and still get away with that from a thrombotic point of view? And the answer seems to be yes, so that WOOST and Pioneer AF and then Redual PCI all found less bleeding when you take away aspirin, and so have dual therapy with a P2Y12 inhibitor and, in the latter cases, a novel oral anticoagulant. Fortunately, the thrombotic events don't seem to be increased even when taking away aspirin. So you use aspirin, obviously, before PCI in the hospital, but then at discharge, stop it. And we saw in Redual PCI like 30 to 50% lower risk of major bleeding and similar rates of thrombotic events. We studied dabigatran in Redual PCI, and the approved dose of 150 milligrams had just identical rates of stent thrombosis, MI, et cetera. So full dose anticoagulation, P2Y12 inhibitor, usually clopidogrel, although we had some ticagrelor, but then no aspirin, and the outcomes were really terrific. And so a recent North American consensus statement, I was a part of it, about 15 of us, did note that with now 3 trials showing this, that this could be sort of the default strategy, that after, or at the time of discharge, that you'd send people home on the dual therapy and allow risk stratification if you had a high thrombotic risk, a left main stent or something, I think maybe a month or more of triple therapy, but to really shift towards this dual therapy as the default. And so we'll see how that plays out. There are some new trials coming, but that does seem to be a nice advantage that we can offer to patients and really reduce bleeding for them.
Issue applied in Ecuador. In Ecuador, the clinical decision should be based on a balanced assessment of 3 competing risks. First, cardioembolic stroke, then coronary ischemic event, and also in bleedings. Non-anticoagulant should be promoted with patients with a score of 0. It is important to promote IRM control in the most anticoagulant using is warfarin. In conclusion, antithrombotic therapy has evolved enough to be useful in treatment various heart problems. Different drugs that reach the receptor necessary to help problems such as acute coronary syndrome or PCI in atrial fibrillation are still being investigated. This therapy should always be regulated by a doctor, and care should be taken when prescribing. Thank you.